Today topic is injury of the spinal cord. Before going into the proper topic, let us recap the anatomy of the spinal cord. Spinal cord has H-shaped gray matter and the remaining portions are white matter. So the inner layer is gray matter surrounded by the white matter, which is the outer layer. So though it is differently colored here, gray matter is inside. It is the inner layer. So this is the anterior horn which carries the motor neurons, and this is the posterior horn which carries the sensory neurons, and this is the intermediate zone, and this is the lateral horn. This is the lateral horn. So anterior horn, posterior horn, and lateral horn in the gray matter, and this is the anterior funiculus, this is posterior funiculus, and this is lateral funiculus, which is in the white matter. And Lissos tract, or the posterolateral tract, which carries the sensory nerve fibers. This is it, and this is the anterior median fissure, and this is the posterior median sulcus. This is anterolateral sulcus. This is posterolateral sulcus, and this is posterior intermediate sulcus. So this is the basic anatomy of the spinal cord. Tracts of the spinal cord. So spinal cord is a place where the ascending and the descending tracts are transmitted. So the sensory information carried by the ascending tracts from the receptors through the higher center goes here, and descending tracts which gives information, so that is from the brain to the effector organ, also crosses the spinal cord. So the major ascending tracts are the spinothalamic tracts. So there are anterior and the lateral spinothalamic tracts which carries pain, crude touch, and the temperature, and there is posterior tract or dorsal column tract, so which is there in the fasciculus gracilis and fasciculus punitus. So other sensations are carried over the posterior column. So other than that, there are spinocerebellar tract. In the descending tracts are there are extrapyramidal and the pyramidal tracts. So the most important tract is corticospinal, the anterior and the lateral corticospinal tracts, and the other tracts are reticulospinal, rubrospinal, vestibulospinal, and tectospinal tracts. So damage to any part of the spinal cord will cause the damage to the information which has to be carried either to the higher center or to the effector organ. Let us discuss the lesions of the spinal cord under the following headings: transection of the spinal cord, lesions of the sensory system in the spinal cord, and the lesions of the motor system in the spinal cord. The spinal cord can get injured at various levels. So if the injury happens at the cervical level, so here you can see at the cervical level, it can cause the tetraplegia, that is the quadriplegia, that is paralysis of all the four limbs. Whereas if it is below the thoracic level, so thoracolumbar, anywhere in the below the T6 or up to the L1, it can cause paraplegia, the paralysis of both the lower limbs. Transection of the spinal cord can be divided into three types. So one is complete transaction. So the connection will be completely lost. Incomplete transaction, and then hemisection. Complete transaction of the spinal cord, the common causes or the gunshot injuries, dislocation of the spine, occlusion of blood vessels. The common site of involvement is at the level of mid thorax. The clinical stages, so produced by the transection of complete transection of the spinal cord, or the stage of spinal shock or the flaccid paralysis, the stage of reflex activity, and the stage of reflex failure. Stage of spinal shock, so it refers to the cessation of all the functions and activity below the level of the injury. So that is the spinal shock. So effects, they depend on the site of the injury. So complete transection in the cervical region, it can be fatal. This is because of cutting the connections between the respiratory center and the respiratory muscles. So this will lead on to the paralysis of the respiratory muscle. So the patient will feel as if they are cut into two. The upper portion, there is a higher center which is unaffected, and then the other side, the other part of the body below the injury level. So that will lose all the sensations and also the motor activity. So the cause of this is it is related to the cessation of tonic neuronal discharge from the upper brain stem. So that is the cause. Duration and severity. So it depends upon the evolution of the animals. So higher the animal, higher level the animal, more profound and longer lasting is the spinal shock. So this is due to the encephalization. So that is greater dependence of spinal cord on the higher centers. So the spinal shock varies from species to species. So it will spinal shock will last only for few minutes in the frogs, few hours in cats and dogs, and for few days in monkeys, and in human beings it can be there for 3 weeks. So the effects during the spinal shock. So the motor effect, they include the paralysis of the muscles. So that the paralysis occurs below the level of the damage. So depending upon the site of the injury, So when both lower limbs are paralyzed, it is called paraplegia, as we have discussed. So there will be loss of tone. So it occurs in the paralyzed muscles. So muscles, they become atonic and flaccid. So that's why this stage is called as stage of flaccid paralysis. And both the superficial and the deep reflexes are lost. Sensory effects, so all the sensations are lost. So below the level of injury. Vasomotor effects, so sympathetic vasoconstrictor fibers, they leave the spinal cord below, that is between T1 and L2. So depending upon the site of the injury, the lesions, they differ. So when there is um, injury below L2 segment, they will not produce any effect. There may be some little fall in the blood pressure. Other than that, there will not be any effect. So injury at the level of T1 segment, that will cut all the thoracolumbar sympathetic neurons from the medullary cardiovascular center. So there will be loss of sympathetic tonic discharge, so that causes the arteriolar dilatation. So there will be fall in blood pressure. So the absence of the tonic discharge will cause the fall in blood pressure. Visceral effects, so urinary bladder is paralyzed, but the sphincter basically regains tone early, leading to the retention of the urine. Rectum, that also gets paralyzed, so bowels become hypotonic, there occurs a constipation. And penis, that becomes flaccid. Erection is impossible in these patients. Remember this. Stage of reflex activity. If the patient survives the stage of spinal shock, so slowly they will regain some of the functions. So that is why this stage is called as stage of recovery or stage of reflex activity. So after 3 weeks, so depending upon the general health of the patient, so the reflex activity, they begin to regain. So to the some of the isolated segments of the spinal cord. So that is below the level of the lesion. So let us discuss one by one. The smooth muscles, they regain functional activity first. So smooth muscle regain functional activity first. So especially the urinary bladder, that becomes automatic. So reflex evacuation is generally established. So similarly, defecation reflex also slowly that gets established. Then sympathetic tone of the blood vessels regained. So when the connector cells in the spinal cord begin to act independently of the vasomotor center. So blood pressure is restored. Skin, which was earlier dry and scaly, now sweating will start and skin will become healthier. Even the wet sores, that will start healing. And then the skeletal muscle tone, they recover a bit slowly after 3 to 4 weeks. So the recovery of muscle tone is reflex in character and is produced by the impulses that enters the spinal cord from the muscles. So the tone of the flexor muscles returns first. Flexor muscles first here. So flexor, they become less hypertonic than the extensor. So here paraplegia in the flexion. So both the lower limbs, they will be in the state of flexion. So no wasting of the muscles seen here. So as there is some tone is maintained, there will not be any muscle wasting. So though the muscles are paralyzed for voluntary movements, they are in constant reflex activity through the spinal reflexes. So reflex activity, they begins to return after few weeks of recovery of the muscle tone. So it is due to the denervation hypersensitivity. We will see later what is denervation hypersensitivity. So flexor reflexes, they return first, and to elicit a flexor reflex, a painful stimuli is required. So the first reflex which usually appears is the Babinski sign. And then extensor reflexes, they return after a period of 1 to 5 weeks. So initially knee jerks appears, then ankle jerk. So generally about 6 months after the damage to the spinal cord, there will be some improvement in the extensor reflexes. So this results in exaggerated extensor reflexes. So slowly then there will be appearance of extensor spasms. And then mass reflex. So mass reflex, so that can be elicited by scratching the skin over the lower limbs or on the anterior abdominal wall. It depends on the level of the damage. So it is by spasm of the flexor muscles of both the limbs. So that will cause evacuation of bladder and profuse sweating will be below the level of the lesion. So this mass reflex, this is utilized to give the this paraplegic patients some sort of control over the bowel and the bladder. So these patients are trained to urinate and defecate. So by intentionally producing the mass reflex, either by tapping over the thigh or the anterior abdomen wall. The recovery of the reflex excitability is due to the development of denervation hypersensitivity. So the remaining spinal excitatory nerve endings which are there in the spinal cord below the level of the lesion, they become hypersensitive to the neurotransmitter. So this is because there will be increase in the acetylcholine receptors. Stage of reflex failure. So when the general condition of the patients that starts deteriorating due to either malnutrition or infection, so the reflexes will become more difficult to elicit. Threshold for the stimulus increases. There will not be anymore the mass reflex, and muscles become extremely flaccid, and there will be muscle waste. So this is the final stage. Incomplete transection of the spinal cord. So here, even if the spinal cord is gravely injured, still there will be some of the tracts that will be intact. It is not completely injured. So the effects of the incomplete transection can also be divided into three clinical stages: stage of spinal shock, stage of reflex activity, and stage of reflex failure. So the stage of spinal shock and the reflex failure, they are similar to the complete transection, whereas the stage of reflex activity, they differ completely. Let us discuss the stage of reflex activity in incomplete transection of the spinal cord. So here it completely differs from the complete transection. Here the tone first appears in the extensor muscle, whereas in the complete transection that appears in the flexor muscle. So this is because some of the descending fibers in the lateral column, especially the vestibulospinal and the reticulospinal tracts, they escape the injury. So both these tracts, they mainly reinforce the activity of the extensor motor neurons. So because of comparatively higher tone in the extensor muscle, there will be paraplegia in extension, and extensor reflexes, they return first. So this can be elicited in this stage, and they are Phillipson reflex and extensor thrust reflex and cross extensor reflex. So there are three extensor reflexes. Phillipson reflex, it is the extension of the opposite limb. So this is produced by gentle flexion of one limb. So the flexed limb then becomes extended and the opposite one flexed. So the response that will alternate in each limb. So this will produce a steppage movement. So this is one of the extensor reflex. And then mass reflex, it is not elicited here. So this is because the controlling effect of the brainstem that persists through the motor fibers. So that have escapes the injury. Charles Edward Brown-Séquard is the first scientist to work out the physiology of the spinal cord. He demonstrated that the decussation of the fibers carrying pain and temperature sensation occurs in the cord itself. So this is, he observed an accidental injury. So in the farmers while cutting the sugar cane in the Mauritius. So he observed all these symptoms and he gave the description. So that's why it is called as Brown-Séquard syndrome due to the hemisection of the spinal cord. Hemisection of the spinal cord. So it is the lesions involving one lateral half of the spinal cord. So the onset here is slow and symptoms they appear gradually. So this is due to the compression by a tumor or damage to the cord. So mostly at the mid thoracic. So the effects, they can happen in two stages. Here the intermediate effects. So it is similar to the spinal shock. So all the effects that happened in the spinal shock appears here. And then the late effects. So the typical motor and the sensory changes that develops after the recovery from the spinal shock. So these changes, they constitute the Brown-Séquard syndrome, and that can be described as changes at the level of section, changes below the level of section, and changes above the level of the section. Changes at the level of the hemisection, so changes on the same side, so sensory changes, so all the sensations are lost on the same side. So this is because of the complete damage to the posterior nerve root, in posterior horn cells in the spinothalamic fibers. So which the spinothalamic fibers, they cross to the opposite side, right? And then the motor changes at the level of the hemisection. So here will be complete lower motor neuron type paralysis due to the damage to the anterior horn cells. So there will be flaccid paralysis of muscles. All the reflexes are lost, muscle power is lost. So there will be muscle wasting. So muscle wasting is due to the loss of muscle tone. There will be complete and permanent vasomotor paralysis due to the damage to the lateral horn cells. And then changes on the opposite side, your sensory changes. So some loss of pain, temperature, and crude touch happens due to the injury to the spinothalamic tract, which crosses horizontally in the same segment. And there might be, uh, but the posterior tract is not affected. So sensation carried by these two tracts are not affected. So only there will be loss of pain and temperature. Motor changes, so there will not be any changes in the motor nerve fibers. So no damage there. Changes below the level of the hemisection, so changes on the same side. So sensory changes, so there will be dissociated sensory loss. So injury to the dorsal column, so that causes loss of fine touch, tactile localization, discrimination, vibration, proprioception, stereognosis. So all sensation loss except the spinothalamic tract sensations, that is crude touch, pain, and temperature. And then motor changes. Here upper motor neuron type of paralysis occurs. So this is due to the injury to the pyramidal tract. In vasomotor changes, so there will be temporary loss of vasomotor tone due to damage to the descending fibers from the vasomotor center in the medulla to the lateral horn fibers. So there will be dilatation of the blood vessels, which leads on to the loss of fall in the blood pressure. So after some time, the intact lateral horn cells, they start acting as supplementary vasomotor center, and the vasomotor turn returns to normal, which normalizes the blood pressure. And then changes on the opposite side, so sensory changes, so the dissociated sensory loss, so injury to the cross spinothalamic tract, that causes the loss of the crude touch, pain and temperature. So all other sensations from the posterior column are preserved. Motor changes, so there will not be any motor changes on the opposite side of the lesion. So in nutshell, extensive motor loss, but little sensory loss on the same side, and extensive sensory loss and little motor loss on the opposite side. Changes above the level of the hemisection, so sensory changes, band of hyperesthesia, so that is increased cutaneous sensations are present in one or two segments above the level of the hemisection on the same side. So this occurs due to the irritation of the neighboring posterior nerve roots, so above the level of the section. So motor changes, there will be twitching of muscles in the upper segments on the same side. So this is due to the irritation of the neighboring anterior nerve roots, so above the level of the injury. So changes on the opposite side, sensory changes, there will not be any change, and the motor changes, no motor changes occur on the opposite side. So regional peculiarities in the hemisection of the spinal cord. So cervical region hemisection. So that causes constriction of the pupil on the same side due to the damage to the dilator fibers that comes through the T1, 2, and T3 anterior nerves. There will be loss of the biceps, triceps, supinator, and pronator joints, and then paralysis of the diaphragm on the same side. So this is because of the involvement of the phrenic nerve, which comes through C3, C4, and C5. And then hemisection in the lumbar region, so there will be loss of knee jerk disturbances in the micturition. This is because of the involvement of the lumbar segment L3 and L4. Hemisection in the lumbosacral region, so there will be loss of control over the sphincters of bladder and the rectum. So bowel and bladder disturbances will be there. So complications of the transection. So patients with the spinal cord transection, they will not be mobilized. So they may be either paraplegic or quadriplegic. So they can develop the following complications: decubitus ulcers. This is because of the posture they are. So due to the compression of the circulation through the skin over the bony prominences in the bedridden patients, especially overweight patients. So these ulcers, they heal very poorly, and they can even develop secondary infections. Hypercalcemia, hypercalciuria, and calcium stone formation in the urinary tract. So this is because of the breakdown of the proteins from the bone matrix. And then urinary tract infections, these are very common because there will be stasis of the urine. So that is because of the paralysis of the urinary bladder. Septicemia, uremia, coma, and death. So this can be because of the severe urinary tract infection or secondary, any secondary infections, any secondary bacterial infections. Lesions of the sensory system of the spinal cord. afferentiation or the dorsal nerve root lesion. So injury to the dorsal nerve root, this produces the loss of all the sensations. So loss of exteroceptive sensations, conscious muscle sense. So that will produce ataxia, loss of unconscious muscle sense. So there will be either hypotonia or the atonia, loss of visceral senses, and then loss of all the reflexes, both superficial and deep, and then muscle tone is lost, marked weakness in the movements. So that will occur because the higher center concern the reflex, the control of posture, they are deprived, they are deprived of the afferent impulses from joints and the muscles. So the muscle will be weak in the movement. Syringomyelia, so it is a rare disease where there will be excessive overgrowth of neuroglial tissues accompanied by the cavitation of the gray matter around the central canal of the spinal cord. So this disease they involve the cervical enlargement more frequently. So the characteristic features of the syringomyelia, sensory features, so they are predominant. They occur in the form of dissociated anesthesia. There will be loss of pain and temperature and retention of touch sensation. And then motor features. So due to the spread of gliosis and cavitation, so flaccid paralysis of the upper limb. So this is lower motor neuron type of paralysis, and this may occur due to the involvement of anterior concepts. Progressive spastic paralysis of the legs. This is lower motor neuron type paralysis. So this progressive spastic paralysis on the legs, this can occur later on due to the involvement of pyramidal and the extrapyramidal types. Taves dorsalis, this is a disease which is caused by the syphilis, in which bilateral degeneration of the posterior nerve roots and posterior funiculi, especially the fasciculus gracilis, occurs. Here, the Taves dorsalis is characterized by lightning pain, so intermittent attacks due to the stimulation of the pain fibers in the dorsal nerve roots in the initial stages, loss of loss or decrease of pain sensibility. So this occurs after some time, and then loss of deep sensations. So the sensation loss on the same side below the level of the lesion. So position sense, vibration sense, sense of stereognosis, and discriminative touch. Loss of reflexes, both the superficial and the deep reflexes are lost. Sensory ataxia. So this is due to the coordination of voluntary involvement. So if a patient walks on a broad base with the legs apart and eye fixed on the ground for just to correct the steps, so then the patient typically raises his legs exclusively highly and slopes the feet on the ground. here in these patients, the Romberg signs, the sign will be positive. The lesions of the motor system, so the lower motor neuron and the upper motor neuron lesions, so they are discussed. So the upper motor neuron is the neuron from the cortex to the spinal motor neurons or cranial nerve nucleus. So if there is any lesion in between, it can cause upper motor neuron lesion. Lower motor neurons are from the spinal motor neuron or the cranial nerve nuclei to the effector organ. So they can be either alpha or gamma. So lesion to this pathway can produce lower motor neuron lesion. Upper motor neuron lesion, so they occurs commonly in vascular accidents or space occupying lesions, and then they will affect the group of muscles. So there will not be any degeneration or wasting. So there will be hypotonia as the inhibitory high control is lost. So paralysis is spastic type. So there will not be any power loss. Reflexes, both the superficial reflex is lost and the deep reflex is exaggerated. Babinski sign is positive. Clonus is present. So this is muscular resistance to the passive movement is exaggerated. So present over here. And the lower motor neuron lesion is seen in poliomyelitis. Also single or individual muscles get affected. There will be muscle degeneration and there will be wasting. So tone is lost. There will be flaccid paralysis. There will be loss of power. Both superficial and deep reflexes are lost. Babinski sign negative and clonus is absent. So management of the spinal cord injury. So they have to get a good nursing care, good nutritious food, and also they have to maintain the fluid balances. They have to prevent the secondary bacterial infections, and they need rehabilitation and constant physiotherapy. To summarize the topic, the spinal cord injury can cause either paraplegia or quadriplegia. So if both the lower limbs are involved, that is called as paraplegia. If it is all four limbs, then it is called as quadriplegia or tetraplegia. So the common types of incomplete spinal cord injury. So Brown-Séquard syndrome, that is the hemisection of the spinal cord, and if the central cord is involved, central canal is involved, that is the central cord syndrome, Syringomyelia. And if it is only the posterior column is involved, that is Taves dorsalis, which is seen in the syphilis. Books to read: A.K. Jain, Hindu Purana, Guyton and Hall, Ganong, and G.K. Pal. Thank you for listening.